Great. So this is a really good segue conversation to a lot of what we talked about from an HRO perspective. But there's a lot of tools available to us that are up and coming and things we can talk about. Again, disclosures for this presentation. I'm not supported by any manufacturer. Clearly, I'll talk about one more than the other. This is what we're doing as an organization and implementing these systems. So again, this is just my opinion and experience. So interestingly, so in these discussions, there's a lot going on with technology and perfusion. Some backs in the 50s in Philadelphia, Dr. Gibbon, you can imagine. So there's a lot of new technology out there, and in the advent of making perfusion easier and safer, I believe. But I think it adds a little bit of level of complexity. Perfusion itself hasn't really much changed. I love this diagram I was given. That's everything that's happening from perfusion when we go into bypass and those kinds of things. So there's a whole lot going on that I think we gloss over and we don't really study well, I would say, or what we do, it's very superficial, and how all these different topics relate. So we start talking about information management and data management and those types of things, what we're looking at starts to become important. And then what do we do with it? And then we all know that really not a lot of great things happen during cardiac surgery. And all these things have a lot of different things, right? So cause and effect, things we look at, change of the month. I mean, I think through time, we all recognize blood management was the thing. And everybody shrunk their circuits up as small as can be. Then only to discover that, oh, hey, guess what? Our AKI rate's going up because now we're, the crits are super high, and how high is too high, and dilution doesn't matter, and all those different variables. And I think that gets into the next discussion point that I wanted to make is a lot of what we do is really this level C of evidence. I mean, take back that, the example that either the STS and the, anesthesia thing, it's, level C of evidence. I mean, it's what we have. It's consensus is how perfusion information education has been involved, and for obvious reasons, the data is just frankly not available. We live in this environment today of this lots of data, the disconnected state. And this is what we look at. We have all these different cool devices, like we mentioned, and, all this data and everything we're doing, and we're involved in registries and everything else. But actually, it's very disconnected. None of these systems really talk to each other necessarily. We talk about interoperability. They're making strides, but it's really interesting from our perspective. I mean, we use a bunch of different, pieces of equipment, but they go in different directions. So ultimately, what's that doing is really sending the information to individuals, and we, again, still operating in silos, a lot of information. Kind of this is where we're starting at. We're on paper there, and it's a fake chart, by the way. And then we go the advent of making improvements. We went to electronic charting, which we kind of akin to texting and driving. So a lot of systems out there, you strap a laptop to it, and then you're just typing instead of documenting. So presents its own challenges and those types of things. So and then you start to the advent of electronic data capture, where you're collecting certain bits of data off of certain devices, but it's really not from an enterprise perspective. So this is a bit of a high level kind of discussion of the differences between electronic and what we're calling a perfusion information management systems. So, clinical documentation and those kinds of things, of course, and billing data, integrating into the heart-lung machine. So a lot of those systems of, historical significance. I mean, way back from when we used to use Yostra and FRealRun, those kinds of things, and then Databond, and now Connect, and the various iterations from Spectrum and whatnot, and then all there in between. If people remember OnCourse way back from Medtronic, that was kind of long ago. But a lot of these registry type things, putting things on a thumb drive, take them to your computer, and download them into a PDF, has pretty much been the answer. Particularly when people look at high tech and stuff like that, they're printing a PDF, scanning it into the HR, and they're calling it we're electronic. Start getting into real-time automated integration and medical devices. So, you talk about these newer devices, connect different things. You're talking to hemodynamic monitoring and everything else. But you start talking about alerts and notifications, and that has a lot to do with what they're designed to be from an FDA standpoint. Then can you, the newer systems need to be like embedded smart checklists, clinical guidances with rate of decay and different sorts of methodology of notification, leveraging different technologies to ease data capture, and leveraging technology for remote views and basically collecting information at various points of care, preoperative, perioperative, and even postoperatively. I think it's important to start looking at systems that are not just in the perioperative period, but really impact, either preoperative state, the perioperative state, and then what we do postoperatively. And we often talk about in our group, a lot of what we do is often measured in the ICU. And it's really, not many places are looking at it from that regard, still in silos. I think you talk about different organizations we talked about earlier, like either ELSO and STS as an example. I mean, a lot of those are, historically what they're done, but, if you look at, cardiac surgery and perioperative series, perfusion and anesthesia do a lot of the medical management and surgeon the mechanical part of it. So how do we bring all that information together and relevant to what we're doing? Some of the systems today, I mean, the Spectrum, and Thales and their situations, I think these enterprise solutions are really the future where we're going. I'll talk a little bit. I'm most knowledgeable about the, Thales's platform, as is what we're implementing in our organization, but and we'll start talking about why. So I talk about it from an innovation versus a revolution kind of thing. So we made improvements, then we innovated. Now I think we're really getting to the revolutionary part of what we're trying to accomplish. And why is it different? Increased case complexity, different levels of safety in cardiac procedures, a lot of comorbidities, and a lot of other things. COVID is just a perfect example of just happening. We're getting cardiac surgery patients, and what do we do with a COVID patient that's a cardiac surgery patient? So all those different things coming true. Incorporating evidence-based practices, and I get back to that last slide. I mean, what really is the evidence, using really discrete data so much than registry, and incorporating multifaceted things, not just kind of siloed events in what we're looking at. And using that leverage, to leverage, more robust data sets and research, and really drive quality improvement. Really eliminate waste and optimize clinical workflows, because I think that's when you start thinking about our prior talk with, crew resource and in the cockpit point of view, it really has to do with that, really bringing the right information to you when you need it. Importantly, as you remember being in an airplane cockpit, there's safety devices everywhere, and you can look all around the room. But you want to focus on flying, and we want to get empowering perfusionists back to being perfusionists, focusing on patient care a little bit less from extraneous documentation. I mean, this is a challenge for all different modalities, nursing and everything else, and it's all talked about a lot. And start to really eliminate needless practice variation. We talk about this a lot in our group, especially as if you go in different areas. People have, these standards of care are really very different in geographies, and, large, excuse me, talk about the reasons why. Getting back to our HRO, it's really the avoidance of errors, the ability to truly avoid errors, mitigate errors when they happen. Having technology available to you that could either recognize or help you recognize an adverse event before it gets to be something critical. And again, hardwire that whole culture of safety. So implementing systems that really matter. So enterprise solutions that, it not just does one thing. So it incorporates the whole session. So where you would integrate into the hospital schedule, so your patient history, barcoding, for accuracy and perspective and documentation. Really start doing that 2-person checklist and all devices, and doing it, the read verify method. And leveraging technology that makes that measurable, using ID swiping and stuff like that. Clinical best practice notifications and from the pre-incision brief. So if we say we're going to do something in a case, we should be able to measure it and then report on it. In leveraging technology for different surveillance models and, dashboard and reporting. So this whole type of thing, which we'll discuss in a couple of minutes, really has to do a lot to do about that whole plan, do, study, act sort of philosophy in clinical quality improvement. But to do this, you need to leverage technology. So you can really start to integrate with everything in the room, not just certain things. We talk about things, when you discuss AKI as an example, People talk about DO2 as an example, but you're missing some of the other things if you don't have capnography involved, or if you don't have integration to other things. So I think the more information you can get from discretely, it creates a greater data set and a greater opportunity to integrate those things, and then frankly automate it in some regard. Reducing medication errors, not being able to chart different, you chart a medication given if it wasn't drawn from Pyxis or whatever system. Those are become process controls that are measurable that can prevent errors. So how much did you give? Like if I note that I gave so much of a dose of a drug, the system would be able to alert and let me know that, hey, you're approaching a nominal limit based on this patient condition. So those types of things currently are all inherent to our clinical practice. And frankly, we should do that from a knowledge base. But, systems and complications being what they are, I think these systems really help. And then we get back into really looking at from the whole fundamentally what we see. And this is a really interesting quote, like a dashboard or a visual display, displaying the most important information needed to achieve one or more of objectives. So that's where we start to get this point of approach is not replacing the alarms that we currently have or different things, but consolidating the information that we really need at the time of care that will most help us. So looking at, trends together and stuff like that. So, basically, automating, for reduced workload, more real-time information, more information and integration that we can start recognizing the relationship between different alerts and alarms. I bring the example, we talk about a cannula malposition. How would that manifest itself really today if we were watching it? You would see if you happen to have like NIRS or cerebral oximetry, you might see a divergence of those things, but arterial pressure would still be going higher. And you might think, oh, I'd be a higher pressure, I got to lower my flow, when in fact you're lowering flow to the head. So leveraging multiple devices in an arena to then consolidate a view and leveraging that technology to better help with care. And really just frankly decrease the distractions around the room. I know many of us probably sit in a room and, the hemodynamic monitor is completely not visible to us because surgeon or anesthesia needs to see it, or somebody shares one singular TV, and that's always fun. So those types of things are important. But the technology exists today. Again, I think this gets into that pre-incision brief discussion is, getting the important information. And I think that the person that commented last one really commented on it. So getting those clinical values either automatically or entering it, and then customizing what you want to do. Maybe you're interested in TAG and those kinds of things or different allergies. These things should be able to be customizable to what's important to you at your practice. And then, be able to set the differences, in those kinds of levels to meet care. And then the systems that we're using today, that goes into the, clinical practice and, basically measure it during the case. And this is an example of what the tau screen looks like from our experience. So you can see, representative different trends. And then, send it into, your pre-incision brief into your cockpit, and you'll be able to, monitor the case from what you've actually been done and are you compliant with your care plan to the pre-incision brief. And then ultimately at the end, measure it. How did I do? Can you aggregate those kinds of things, and then turning that stuff into reportable handoff tools for the ICU and then for the surgeon that, I had an issue in the case. Like, we like to have, again, part of our look-see at this on our side is, any alerts or alarms that went off, did those kinds of things. How many times do we have high pressures from them lifting up the heart and they didn't think it's our fault, or I can't empty the heart and those kinds of things. So all these things become, manageable and just in a discussion point when you're able to present data to your colleagues. So I think that's really important. And ultimately what that does is really start to revolutionize the quality process. So, you plan it, you measure it, you study it, and then you keep going back and forth. So, making meaningful changes as you revolutionize this process. The last thing about doing is, okay, once you do this, what is a clinical decision support engine and what they are? Essentially, they're guidance engines. A lot of people think about different things like AI and different things like that. That's not what we're really talking about there. This is really using information that are at hand that we, as clinicians, can aggregate in a form that, according to our protocols, and give us reminders, verifications, contextual alerts and alarms or alerts to let us know what we're doing. So you don't deal with that alarm fatigue, whether they're up or down. many times you basically see, somebody's leaning on the A line, and all of a sudden, oh my God, the pressure's down. And, if you're not paying attention, somebody might start giving a pressor, and all of a sudden the pressure's super high, and then you start chasing the tail. These types of things would allow us to, using technology, is to leverage that type of thing where, things don't correlate. We'd be able to identify those things before adverse events can happen. Again, using our HRO philosophy of mitigating those things should they happen, because those things are going to happen. And then so the goals of them again are, patient safety and compliance initiatives, outcomes research, again, using the data that is meaningful in a very robust sense. Operational management, how long were cases? How do I schedule? How long did they really take? What kind of departmental resources do I need? When you actually start using this actual data, room time, patient time, all those different things, it becomes really interesting. And then really identifying harmful trends over time, in a more real-time sense. I mean, a lot of us participate in the registries at our hospitals, but you meet maybe once a month or once a quarter, and then you look at information that was 3 quarters ago and saying, hey, we're doing pretty good a couple months back, and how can we improve now? So I think those types of things is leveraging the opportunity of clinical data and outcomes information really at the point of care, and then shortly thereafter, so teams can look at those things. Those were when we talk about the whiteboarding events and different things from our HR modeling, is looking at this information in more real time. So you were empowering quality and compliance people to really ensure alignment of best practice. I think that's really important. And then again, the goals, we can set different levels of limits, from a institutionally, surgeon specific, even our own personal, departmental specific, so we can make sure we meet those goals. And then, operational guidance in various avenues, be in the cockpit or some maybe a pump room surveillance module. So we know if we have multiple rooms in one institution, or somebody's, the backup person for the day, they might receive an alert that says, hey, room 2 is having an issue. You might need to get there before somebody has to go over to the phone. So it's preempting those things and mitigating any potential bad errors. So leveraging technology and information to better patient care. Obviously, compliance and analytics example, I think we talk about this again, using those kinds of storing and, how compliant are we to what we're doing? And then again, this gets back to really the conversation we had earlier, is high reliability bills, have systems in place that make them exceptionally consistent in accomplishing their goals and avoiding potential errors. Again, I can't emphasize this enough, is we have this technology available to us. I think it behooves a lot of us from a departmental standpoint is to go to our organization and say, hey, we really want this and we really need this. Regardless who you choose. I mean, I think there's some really great technology out there and it's constantly being developed. So again, we support the one we like, and so there's many different areas. Really, ultimately, what does an information management HR, it really leverages that to radically improve safety, quality, and workflow, especially decreasing distraction. I think that's really important. Better decisions and better care. I mean, I often tell a lot of people that, especially in our surgeon colleagues in anesthesia, people make really good informed decisions with more information. Nobody's really intentionally making a bad decision. I think the more information and the better quality you're going to get, you're going to do well. Clinical guidance is, again, that's team approach, and that can only get better with better data. And then again, really revolutionizing care and outcomes. So I think really the quality, the future of all this is integrating all these different things in technology to, real-time clinical operational goals to improve quality and safety. So I think that's where we're going and what we need to be doing, and the technology is available today. So with that, we can have some discussion, I hope.